Our next presentation by Dr. Ying, Zhang, and Dr. Christina Miles. This is going to be a case discussion of vaginal bleeding in pre-menopausal patients. Dr. Ying Zhang is a family physician and the faculty in the Department of Family Medicine at the University of Washington. She practices full spectrum family medicine, including inpatient, OB, and outpatient primary care at the Harborview Family Medicine Clinic. She is the co-director of the Reproductive Health Care Advocacy Fellowship at UW. And Christian Ying, please feel free to share your slides as I introduce you. Dr. Christina Miles is a current fellow in the Reproductive Health and Advocacy Fellowship at the University of Washington. She completed family medicine residency at the University of Washington and is a member at large of the King County Academy of Family Physicians. Christian Ying, thank you for joining us today. So the floor is yours.
Thank you for having us.
Oh, sorry, Ying. Thank you for that introduction, and hi, everyone. So we are going to be presenting about abnormal vaginal bleeding in premenopausal patients, recognizing that there are many different times in life that people may be experiencing vaginal bleeding. We have no financial disclosures. And our first half of this presentation will focus on the evaluation and management of abnormal uterine bleeding outside of pregnancy. The objectives will be to define abnormal uterine bleeding and provide an overview of the most common causes amongst premenopausal non-pregnant patients, as well as to describe the management and efficacy of treatment options for heavy menstrual bleeding in this population. Abnormal uterine bleeding affects many people, up to 14% of reproductive age people with a uterus. And there has been new terminology introduced in the past 10 years. In 2011, the International Federation of Gynecology and Obstetrics met in the Menstrual Disorder Working Group and developed new terminology for us to use. So the prior terms of menorrhagia, metrorrhagia, and dysfunctional uterine bleeding are no longer preferred. And instead, this FIGO 2011 working group created terminology and definitions based on frequency, regularity, duration, and volume of menstrual bleeding. Terms like amenorrhea, primary and secondary amenorrhea, and menopause are still unchanged and remain accurate. We just have different classifications for bleeding outside of these examples. We are going to try to set up a poll for this next question. So if you see a poll pop up, please answer it. But if you do not, feel free to type into the chat what your answer will be. What would you categorize as normal frequency of menses of these options? So please just answer poll number 1 for right now. We'll save poll 2 for later in the presentation. Oh, it looks perhaps like we're not able to submit if you don't answer both of the questions right now. So please feel free to use the chat, and that is just fine. I'll give everybody a second for this one. Great, starting to see some answers coming through here. Answer D is correct. Infrequent menses is longer than a 38-day cycle, and normal is between 24 and 38. Anything less than a 24-day cycle is considered frequent. The FIGO classification also asks us to describe regularity, and this is considered based on the number of days of variation over a 12-month period. So irregular menses is if there is more than 20 days of variation over 12 months. This can be a little bit of a tricky concept to wrap your head around. So as an example, if a patient's typical cycle is 28 days in length, however, 4 cycles per year, it was 32, then we'd calculate the variation by being the difference between the cycle length in these different periods times the number of cycles that there was variation. So this overall would be a 16-day variation over the year and be considered regular menses still. In considering volume, normal volume of menstruation is 5 to 80 milliliters. I think we all know that estimating blood loss can be tricky both for doctors and patients. A helpful marker would be thinking about a normal size tampon or normal size pad. If that was soaked, that would be about a teaspoon or 5 milliliters of blood loss. So a total of 1 to 16 normal size pads or tampons that are soaked during a menstrual period is considered normal blood loss. And in terms of normal duration of menses, normal is 4.5 to 8 days. And then on either end, menses shorter than this would be considered shortened, and any longer would be considered prolonged. We're going to consider a case of a 23-year-old cisgender female who presents with concerns around her menses. Her periods have been very regular in the past, but she's noted some changes in the past year. She has regular cycles every 23 days that last 7 days, and she's using 4 to 5 pads on her heavy days, which can last for up to 3 days. She works as a fitness trainer, and the bleeding has been difficult for her to manage while working. And I want you to consider, but you don't have to type into the chat, how would you categorize this menstrual bleeding in terms of frequency, duration, and volume? And as a reminder, here are the details for her current menstruation. So this would be considered frequent bleeding as it's less than 24-day cycles, normal duration at 7 days, and likely would be heavy in terms of volume if she's using 4 to 5 pads for 3 days, so already getting up to 12 to 15 pads, and then has an additional 4 days of bleeding. The FIGO 2011 working group also recommends use of this palm coin mnemonic to think about etiologies of abnormal uterine bleeding. Some people may already have been familiar with this from other times of medical education, but highlighted both from that working group and an excellent AAFP review article in the past year. So the palm half covers structural etiologies of abnormal uterine bleeding, including polyps, adenomyosis, leiomyomas or fibroids, and then malignancy and hyperplasia. And then the coin half is the non-structural etiologies, so coagulopathies, ovulatory dysfunction of any etiology, knowing that that can come from numerous different causes. Endometrial is actually getting at abnormal endometrial hemostasis, so is a relatively uncommon cause. And then iatrogenic and infection encompasses many different things, including STIs, as well as many medications that can affect bleeding. And then the not otherwise specified category is getting at things that are also uncommon, like AV malformations, C-section scar defects. So really some of your diagnoses of exclusion. And I want you all to consider for a moment before we move to the next slide, what exam you may perform or what tests or questions you may inquire with to think about these different etiologies for a patient in your office. Okay, so for thinking about both polyps and leiomyomas, we're really going to need to rely on our pelvic exam initially because questions and history may be a little bit less helpful in truly identifying these as causes. For adenomyosis, it can be helpful to ask patients about the presence of pelvic pain. And for malignancy and hyperplasia, we really want to consider any risk factors for cancer, including personal and family history and history of unopposed estrogen use. Though there are many other minor criteria or risk factors as well. In coagulopathy, asking about history of prolonged bloody noses, bleeding with dental work that has been notable. In ovulatory dysfunction, making sure to ask about regularity of periods. If there have been any significant weight loss recently and thinking about changes in hormone level, like with the female athletic triad. And then possible etiologies like prolactinomas with headache or galactorrhea. This endometrial hemostasis disorder is pretty uncommon and also an area of exclusion, so no big questions to think about there. But in terms of iatrogenic, taking a really careful look at all medications, including over-the-counter things, but with special attention to any hormonal contraception that patients may be using, as that can be a common side effect. And then cluing in to any postcoital bleeding and considering the possibility of STIs. Many of these working groups, as well as Ying and I, recommend always remembering to get a urine pregnancy test for patients with abnormal uterine bleeding, considering getting a CBC, and then remembering to collect a pap smear if they are due. To come back to our case, our patient has had no new stressors, no changes in her exercise routine, no significant weight loss. She has no risk factors for cancer, has not had any headache or galactorrhea, no history of prolonged nosebleeds or bleeding with dental work. She's had one sexual partner in the past year and has not been tested for sexually transmitted infections recently. Her vitals are stable and her pelvic exam is normal. There are no masses appreciated on bimanual exam, and a gonorrhea and chlamydia swab was obtained. She feels like she may have to quit her job if the bleeding cannot be controlled. What do we think about for her management options? This is divided up between medical in the left-hand column and surgical options for management of abnormal uterine bleeding, and then further divided up amongst options for patients desiring pregnancy currently and those that are not. And remembering that options that may be most effective for bleeding may not be the first choice of the patient. So we're lucky to have lots of different choices. One that may be newer or less familiar to people is tranexamic acid, or TXA. The brand name is Listata for the oral formulation. People may have had more experience with this in emergency room settings, as it's often used in trauma cases, and then much more frequently these days on labor and delivery for patients with postpartum hemorrhage. But it was actually FDA approved as an oral formulation for heavy menstrual bleeding in the US in 2009 and has been used for much longer in other settings for this indication. Tranexamic acid is an antifibrillinic agent, and it competitively blocks the conversion of plasminogen to plasmin. So it's reducing fibrinolysis. And through that mechanism is effective for heavy menstrual bleeding. And then some of the other ones are likely familiar, combination estrogen and progestin formulations, whether COCs, patches or rings, progestin-only pills, depo-medroxyprogesterone acetate or DMPA, and the levonorgestrel IUD. We're going to mostly be focusing on the medical options, as that is really our first line for all patients. And I want you to consider what medical option in this list do you think would be the most effective option to reduce bleeding in patients. Okay, so amongst our medical options, these are the relative percentages of reduction in blood loss seen with all of them. Tranexamic acid and TXA and NSAIDs can both have up to a 50% reduction in blood loss. And then amongst our hormonal options, combination estrogen and progestin, whether this is through pills, patches, or rings, can be up to a 75% reduction, but you'll notice that this can be pretty variable. And then progestin-only pills can be up to 87% effective in terms of reduction of blood loss, but this is specifically with continuous use, which may be different than how some patients are using or prefer to use progestin-only pills. For depo-medroxyprogesterone acetate, there was not a specific reduction in blood loss data available. It's not actually very well studied for heavy menstrual bleeding, nor a high-level recommendation for this indication, but 50% of users have amenorrhea at 1 year. And then levonorgestrel IUD is definitely the most effective in terms of percent reduction in blood loss, up to 95% reduction in bleeding. So a little bit more detail on these options for our patient. The levonorgestrel IUD with this up to 95% reduction is based on use of the 52 milligram device. So this is the Liletta or Mirena brand names that release 20 micrograms per day of levonorgestrel. These devices have been well studied for contraceptive efficacy up to 7 years, though the FDA label is not quite there yet. But it's good to know that the effect on bleeding suppression can wane before the device loses contraceptive efficacy. So it's completely okay to replace it earlier if that is the indication you're using it for your patient. And also reassure them that return of bleeding does not mean that their device is no longer effective for birth control. Tranexamic acid or Listata is dosed at 1,000 to 1,500 milligrams PO 3 times daily for use only during bleeding. Because of its mechanism, this should not be used for patients that have an underlying increased risk of thrombosis, but is pretty special in that you can use it for patients that are trying to conceive but still struggling with heavy menstrual bleeding that is affecting their life. Because of this risk of thrombosis, we should not use this in combination with COCs, because that can have additive effect, but can be potentially used in combination with other methods. For estrogen and progestin containing contraceptives, there will be greatest efficacy in improving bleeding with the higher dose of ethinyl estradiol, so the 35 microgram dose. It's okay to use patch or ring formulations, but consider using either extended or continuous dosing to have greater effect at bleeding suppression. So there are formulations of pills available where there are 84 days provided in the pack of hormone-containing pills, and then just a week of either placebo or low-dose ethinyl estradiol. But you also can recreate this by just providing patients with more packs of a monthly pill, and they can create their own extended or continuous regimen. For progestins, both norethindrone or medroxyprogesterone acetate can be used. However, this is significantly less effective as a method to suppress bleeding if only used during the luteal phase. Continuous use is very effective, or if patients prefer to have cyclic use, you should start dosing on day 5 of the menstrual cycle and then take daily for 21 days. And then depomedroxyprogesterone acetate, just to highlight, is available both as an intramuscular injection as well as a subcutaneous injection that's also once every 13 weeks. There has been less use of the subcutaneous version in the past because it's not available yet as a generic and it's a little bit more expensive, but there's been a lot of interest in more use of this during the COVID pandemic, as patients don't want to come into clinic just for a birth control shot or use for bleeding, and so can potentially self-inject this at home. We've had really good luck getting this covered for patients with their insurance in Washington state so far this year, but is something to think about. However, with this method for control of bleeding, it's really, really common to have unscheduled bleeding upon initiation, though 50% of people may reach amenorrhea at 1 year. And then NSAIDs are probably an underutilized method, especially because you can combine this with any of the other therapies. Consider dosing naproxen 500 PO twice daily during bleeding, and just remember not to use this for patients with underlying coagulopathies. And then I really love this overview from a recent AJOG review. It goes through the order of recommendations for method to control bleeding, depending on what the etiology of abnormal bleeding is. So we've been focusing for our case on ovulatory AUB, a patient who's ovulating regularly but is still having heavy menstrual bleeding. And so in this population, the levonorgestrel IUD is the most effective method, but you can see here an order of suggestions to consider going through. In contrast, patients with ovulatory dysfunction will likely have greatest efficacy with a combined oral contraceptive to have greater control of the ovulatory cycle. And then for patients with symptomatic leiomyomas, levonorgestrel IUD is also the most effective method, assuming that patients do not have a distorted uterine cavity that's prohibiting correct and successful placement of the IUD. In inherited bleeding disorders, tranexamic acid is actually our first-line therapy. So nice to have that kind of on the radar as a newer therapy. And then for patients on anticoagulation therapy, levonorgestrel IUD is also the most effective method, though we have multiple other options as well. And we'd really be cautious about thinking about tranexamic acid depending on the indication for why patients were on anticoagulation therapy, because if we're treating something in terms of recent clot, then something that's going to be promoting clot formation is probably not our #1 choice. So the use of levonorgestrel IUD for best bleeding control, though patients may have many other considerations for what their preferred method is most effective. This is a Sort A recommendation for the 20 microgram per day formulation. And this is better than other medical therapies, specifically in reducing heavy menstrual bleeding. This performs similarly to hysterectomy when we adjust for quality adjusted life years. And this is also supported by a 2020 Cochrane review showing improved control of heavy menstrual bleeding compared to other medical therapies and similar performance to endometrial ablation. Our key take-homes here are to use the FIGO 2011 classification to both define and accurately describe abnormal uterine bleeding in terms of frequency, regularity, duration, and volume, and to also use the FIGO 2011 mnemonic PALM for structural and COIN for non-structural causes of abnormal uterine bleeding. And then levonorgestrel IUD is our most effective non-surgical option for bleeding control. but tranexamic acid is a newer option just to be more aware of that is safe for people desiring pregnancy. And I'm going to switch over my screen share right now.
Can everyone hear me?
Yes.
Okay. If it's okay, I'm going to keep my camera off while I'm talking, and then I'll come see you guys again when we're answering questions. So the next part of our presentation is going to focus on the evaluation and management of first trimester bleeding, which is a very common occurrence, occurring in up to a quarter of pregnant women in the first trimester. So in addition to discussing the evaluation and management of first trimester bleeding, we're going to review some newer evidence for management of early pregnancy loss. And again, we want to present this information with a clinical case in mind. So consider a 32-year-old cisgender female who has had vaginal spotting for the last 3 days. Over the weekend, she took a urine pregnancy test that was positive. Her vital signs are normal and she's well appearing. Her last menstrual period was October 3rd, which puts her at about 6 weeks gestation, and she reports that her periods are irregular. On physical exam, you note no abdominal tenderness to palpation, and her pelvic exam and bimanual exam are unremarkable, and the cervix appears closed. Her labs come back with a serum beta-HCG of 1800, a hemoglobin of 14.5, which is normal, and then a blood type of A positive. Her transvaginal ultrasound findings are here, showing an empty uterus. So on her ultrasound, there's no intrauterine pregnancy. In addition, in other pictures, there were no adnexal masses and no free fluid seen on ultrasound. We are going to try another poll question, and let's see if this works. So please go ahead and choose your diagnosis for this patient: ectopic pregnancy, missed abortion, inevitable abortion, or pregnancy of unknown location. And Simone, will we be able to see the results?
Yes, I'll show the results. We're at about 46% completion on answering.
Thank you. I think once we get a little bit more, you could probably just go ahead and show it. Great. So it looks like many of you chose pregnancy of unknown location, which is correct. Before we move on to the next slide, I wanted to just talk a little bit about terminology. So you will hear me use the terms early pregnancy loss, spontaneous abortion, and in addition, miscarriage. And all of those can be used interchangeably to describe a non-viable pregnancy in the first trimester. As you saw with the answer choices, there are many different types of spontaneous abortion, and that includes inevitable abortion and incomplete abortion. In both of these cases, patients present with symptoms, which can include vaginal bleeding or lower pelvic pain, and the cervix appears dilated on exam. In an inevitable abortion, the products of conception or pregnancy may be felt or visualized through the internal os, while in an incomplete abortion, products have started to pass and may be seen in the cervical canal on exam. In a missed abortion, patients may present with or without symptoms and have a closed cervical os on exam. And lastly, the term is not on this slide, but threatened abortion is another type of clinical presentation with first trimester bleeding, and patients can present with symptoms in a closed cervical os. But in these cases, patients do not yet meet diagnostic criteria for early pregnancy loss. Looks like I'm not able to oops, sorry about that. Okay. So for pregnancy of unknown location, we are really talking about pregnancies in the case when a pregnancy test is positive, but neither an intrauterine pregnancy or an ectopic are seen on ultrasound. The management for this is follow-up serial quantitative serum beta HCG testing and follow-up ultrasound. Of note, an increase in beta HCG can be similar among people who have early viable pregnancy, an ectopic pregnancy, or early pregnancy loss. So the value of serum beta HCG is not necessarily going to be diagnostic. In addition, when you do recognize a pregnancy of unknown location, it's always really important to counsel patients about warning signs of ectopic pregnancy because that has not been completely ruled out. And it's important to assess for risk factors for ectopic pregnancy. And I've listed some of those here on this slide as well. I wanted to spend some time talking about labs in the workup of first trimester bleeding, and specifically serum beta HCG. So I think the school of thought, or many of us have been taught that we expect early in pregnancy the serum beta HCG to double in 48 hours. However, in studies, the amount of rise or the least amount of rise in 48 hours can really be variable depending on the initial serum beta HCG. And so when the serum beta HCG is less than 1500, for a viable intrauterine pregnancy, it should rise at least about 50% after 48 hours. When it's greater than 3000, that rise may be even less at 33%. And again, the rise can be variable. 99% of the time, an intrauterine gestational sac will be detected at a level of serum beta HCG at about 3500. And many of you may have been taught and remember that the cutoff for the serum beta HCG at which you should see an intrauterine pregnancy is about 2000. But just know that that value can be a little bit variable too. If there is a slower rate of increase or even a decrease of serum beta HCG, this may be concerning for early pregnancy loss or ectopic pregnancy. And in general, the serum beta HCG plateaus around 10 weeks of gestation. One of the other lab values to consider for first trimester bleeding and diagnostic workup is serum progesterone. It may help to distinguish between early viable and non-viable pregnancies when the patient has an inconclusive ultrasound. So a 2012 meta-analysis of cohort studies looked at serum progesterone and found that a value of less than 6 nanograms per milliliter in women who presented with symptoms, which included vaginal bleeding and or pain, and had an inconclusive ultrasound, excludes a viable pregnancy with 99% negative predictive value. So, and then it's important to note that serum progesterone doesn't necessarily distinguish between an intrauterine pregnancy and an ectopic pregnancy. So when you have inconclusive ultrasound findings and you still don't know if you have an IUP or an ectopic, it's possible that serum progesterone can still provide some more information on or when you have an IUP and you're just not sure if it will be viable, it can be used. And really, I think the caveat and the reason why I don't see it used very often or ordered as ancillary information is that it can be an extra cost and it may not change your management of the patient. For example, if it's a desired pregnancy, the standard of care is still to get serial beta HCGs and follow-up ultrasound. The setting where I think it could be useful is if patients are very anxious or desire more information during that waiting period when you're waiting for serum follow-up serum beta HCG or ultrasound information, and especially in the case of patients with recurrent miscarriage where it might just provide some ancillary information. So in our case, as it continues, you repeat a serum beta HCG in 48 hours and it comes back at 4,500. The original was 1,800. And at this time, you do a transvaginal ultrasound that shows a gestational sac with a mean sac diameter of 27 millimeters. There's no yolk sac or embryo. The patient is asymptomatic at this time. Is this a viable pregnancy? So for the ultrasound, it was a 27 millimeter mean sac diameter, which is greater than the cutoff for diagnosis of early pregnancy failure without an embryo. The purpose of showing this table is just to show you all that the Society for Radiologists in Ultrasound and ACOG has endorsed these guidelines, have created these guidelines for the transvaginal ultrasound diagnosis of early pregnancy loss and early pregnancy failure. And so this can always be referred to if you have questions about ultrasound findings. So in our case, the patient is diagnosed with early pregnancy loss. She's open to all options and she'd like to pass the pregnancy as quickly as possible without needing a procedure. What is your best option for management? So we have a few different options. Those include expectant management, medical management, and uterine aspiration, which are all safe and effective treatments in general for early pregnancy loss. We'll spend a little bit of time talking about each. For expectant management, it is absolutely safe in the first trimester for patients with stable vital signs and no signs of infection. There's no good safety data for expectant management in the second trimester of pregnancy. As we know, in second trimester, bleeding and complications can be higher. Expectant management has 81% efficacy for all comers with early pregnancy loss, but the success rate really varies by the type of spontaneous abortion or miscarriage, with incomplete or inevitable abortion having the most successful rate at 91% of patients who will progress to complete within a month. Expectant management is a little bit less effective compared with medical and procedural intervention in patients with anembryonic gestations or embryonic demise. In general, with expectant management, patients may have more days of bleeding, a longer time to completion, and higher rates of unplanned surgical intervention compared with medical management. Serious complications are rare. And then people often ask, how long can you wait with expectant management? And it's absolutely safe to wait as long as patients may wish and as long as there are no signs of infection or hemorrhage. For medical management, this is where we have our newer evidence. So the mainstay or standard of care historically or traditionally for medical management of early pregnancy loss has been the use of misoprostol. Misoprostol is a prostaglandin E1 analog. While it's FDA approved for prevention of gastric ulcers, many of you know that it's used off-label for many obstetric and gynecological conditions, including labor induction and cervical ripening, management and treatment of postpartum hemorrhage, and then it's added to mifepristone for medication abortion. For misoprostol alone, the largest randomized control trial showed that after one dose of misoprostol, the success rate of management of EPL was 71%, and this increased to 84% after a second dose of meso. So our most newest evidence from a randomized controlled trial done by Schreiber et al. At UPenn in 2018 shows that mifepristone pretreatment with misoprostol is more effective than misoprostol alone for early pregnancy loss management or medical management. And I included the regimen on this slide of 200 milligrams of oral mifepristone and then 800 micrograms of vaginal or buccal misoprostol about 24 hours later. If mifepristone is not available to you at your practice, it's absolutely okay and efficacious to use misoprostol alone for medical management. And I did put on this slide that incomplete abortion can be considered a little bit differently in that medical management versus expectant management doesn't improve the rate of completed abortion for incomplete abortions. And it also doesn't necessarily decrease the need for unplanned surgical procedures. For incomplete abortions where the pregnancy has started to pass, misoprostol alone has been very successful for medical management. And then lastly, the uterine aspiration is another option. It's the preferred procedure for surgical management of early pregnancy loss. It can be done as an office-based procedure and is safer, less expensive, and more convenient than treatment in an operating room. And it's appropriate for anyone who desires immediate management. And then just to review our key points for this part of the presentation, in that there are guidelines for ultrasound diagnosis of early pregnancy loss. So definitely use those if you have a question. Serum progesterone may be used to predict pregnancy outcomes for patients with symptoms and indeterminate ultrasound findings. And mifepristone pretreatment with misoprostol is more effective than misoprostol alone for medical management of early pregnancy loss. And we will take questions.
Thank you, Ying and Christy. I'll give you the questions. If you could stop sharing your screen. Question from Gina. What is the mechanism for NSAIDs to work in abnormal uterine bleeding?
I love these mechanism questions. Yay for mechanisms. So NSAIDs suppress prostaglandin synthesis by inhibiting cyclooxygenase, but they also affect the equilibrium between thromboxane A2 and prostacyclin. So they increase thromboxane A2, and in this way are increasing platelet aggregation. They're promoting vasoconstriction and reducing overall menstrual blood loss. So a couple different ways they're doing that.
Thank you, Christy. Question by June, I think was answered also by Gina, but if you can add something to it. Cost of tranexamic acid, and does it need pre-authorization? Gina said by GoodRx is $26.49. Does it need prior authorization?
I may defer to some of my more experienced colleagues on this, but I also looked up just the without GoodRx price. So the Listata brand name is $179 for a month, and then the tranexamic acid generic is $113 per month without that GoodRx price. As someone very, very early in my career, I have not run into prior auth issues with this, but I'd be interested if anyone else has.
I also don't have an answer for the requirement for prior auth. And then I imagine it may vary by indication too, and the types of management that patients have tried prior to prescribing this. But if other people have experience, please do contribute.
Yeah, feel free to share in the chat box. Question by Nancy. What's the role of ultrasound in evaluation of abnormal uterine bleeding?
This is also great. Okay, if it's okay, I'm going to share my screen for one more second because there's a really great algorithm from the most recent AAFP review article about workup for abnormal uterine bleeding that we didn't include because it's kind of a dense slide flowchart, but I think it will answer a couple of questions that have come up. One second. Okay, so here we have a suggested algorithm for workup of abnormal uterine bleeding. So we're starting first with our structured history and physical exam that we've been talking about and making sure everyone's getting pregnancy tests, CBC, consideration of cervical cancer screening. But to come down to where we're going to have an indication or recommendation for an ultrasound, it's really if patients have abnormal bimanual exam findings or if their symptoms are really persistent despite first-line treatment. Checking to see if you're missing something with a transvaginal ultrasound is really reasonable. Also, consideration of a saline-infused sonogram could be an option if you're thinking more about intracavitary lesions that may be less well captured on a transvaginal ultrasound. And then I also had seen a question, just while we have this up, about consideration for workup for PCOS. Is that okay if I answer that right now, Morha? Okay. So similarly, if you hop over one slide here, thinking about more workup for hormonal causes, should be considered in patients that have irregular menses that are suspicious for you that they may not have regular ovulation. So that's when PCOS may be a consideration. But other clues for PCOS would be if patients have heavier body weight, have hirsutism, or have really persistent acne. All of those things can go along with having higher androgen levels, and together with irregular menses, that would probably be your clue to go looking in that direction. There was a question, I think, by the same person about when to think about endometriosis. And I think this is a really tricky one because we often group endometriosis in our head with like problems with menstruation. But really, endometriosis will less typically present with heavy or irregular bleeding. The biggest feature for endometriosis is pelvic pain with menstruation, or sometimes at other times as well. Its cousin that definitely falls into the heavy menstrual bleeding workup category is adenomyosis. So if there's endometrial tissue that is within the myometrium, so having a larger uterus on bimanual exam or heterogeneous appearance on transvaginal ultrasound would be consistent with possible adenomyosis. It's just a little bit less common to have the heavy bleeding with endometriosis, though closely related.
Question by Gina. Could you share again the regimen for misoprostol alone? Was it 2 doses, 1 doses, and how many milligrams?
Yeah, so misoprostol has multiple routes of administration: oral, buccal, sublingual. Oh, my brain just farted. Oral, buccal, sublingual, and vaginal. Sorry. So many of the studies have looked at different routes of administration, but the most common routes are vaginal and buccal. All of the oral types, so oral, sublingual, and buccal, will have more potential GI side effects. The dose is 800 micrograms, although several different doses have been studied, but traditionally the most common dose is 800 micrograms of either buccal or vaginal meso for a one-time dose. And then if there is no bleeding that happens after that, then patients can redose in 12 to 24 hours. And it really just depends on the patient's response to the first dose of meso. But the article that I had referenced with efficacy of 1 dose versus 2 doses did show an increased efficacy after the second dose of meso for passage of of the pregnancy.
Thank you. Question by Leah. Do you have any guidance for providing on talking to patients about TXA and clotting risk? Any good resources? Thank you.
I do not have a ready resource at hand, but what I would say is that there has not been super large size trials that are really showing increased rates of thrombosis. It's the fact that this is a really significant theoretical concern, and that the current FDA label is saying that this should not be used as a contraindication if people have history of VTE, elevated risk of thrombosis, and then the current use of COC is also used as a proxy for increased risk of thrombosis, as that being an independent risk factor. But there have been several trials in Britain and in Sweden that did not necessarily show that people were having an increased risk of thrombosis. So it's, I think, an area of ongoing investigation. And I probably would talk to people that were at low risk of saying this is a small increase and in risk, and maybe largely theoretical, but making sure that they're aware of that possibility. If I come across a better resource, I can try to share that back.
Of course, we can share it with everyone. Can you share a quick reflection on telemedicine and abnormal vaginal bleeding? What are some cases you can manage easily from home? What are some cases when you have to see the patient in person? Of course, in the absence of concerning symptoms or signs regarding stability.
So I would say this is super case dependent, and I will see if Ying has any additions. I think a lot of discussion about heavy menstrual bleeding is really reasonable to have an initial discussion remotely, because if patients have, slight variations from their normal bleeding, or have access to things like pregnancy test at home, and you're able to say, you seem stable and things are not life-threatening right now, working through your initial options, or especially if you have an offending medication or use of a hormonal contraceptive that may be the clear etiology, you could trial treating or modifying a lot of those things remotely. But I think because the need for a pelvic exam for some considerations, but also if patients don't have access to doing a pregnancy test, considering some of those more potentially like critical problems that could be masquerading as just changes in menstrual bleeding for a lot of folks coming in person. So could be helpful. For example, Ying and I saw a patient yesterday who had an IUD in place and had been having some new spotting for a couple of months, even though she'd had the IUD in place for a couple of years. And on exam, the IUD strings were missing, and then her pregnancy test was positive, and she ended up having an ectopic pregnancy. And so I think, you know, some of those things could be sussed out a little bit remotely if patients have access to rule out dangerous causes. But if they don't have access to those resources right now, in person may be helpful just to make sure you're having a comprehensive first pass for anything dangerous.
Yeah, I agree with Christy. I think especially right now in the time of using telehealth and where we have it available, it's really important to spend a lot more time on our history, and then also thinking about risk factors, minor and major risk factors for some of the more dangerous things like ectopic pregnancy and other causes of the bleeding. And so kind of going through with the patient whether they meet any of those risk factor criteria can help you prioritize further management or workup.
Thank you very much, Ying and Christy, for this engaging and thoughtful presentation. Appreciate all the information. It's time to go to our next break. So please take a break, come back at 12:45. Staff will try to move people